In keeping with our usual format of our meeting, as you all probably are familiar if you've been to our meetings before, we have a presidential symposium which will be of the highest ranked abstracts, and that's tomorrow. But there were a couple of other abstracts that were also very highly ranked, and we've asked them to give brief presentations. After these two presentations, we will have a break so you can get up and stretch for a bit, and then we will begin our poster session. And our poster session is we're utilizing a platform called Spatial Chat, where you literally drag your icon next to the poster, and you can view the poster, talk to the poster presenter, very much like what you do in person. So I just wanted to point that out. So after the break, we'll come back. You'll click on the link through the platform to get to the poster session. And then after the poster session, in the first 30 minutes of the poster session, we asked the presenters to stay by their posters so people could speak to the specific posters they're interested in viewing with the presenter there. But then after the poster session, we will have our virtual welcome reception, also in Spatial Chat, where we can have an opportunity to just mix and mingle. So get your cup of coffee, your glass of wine, whatever is appropriate to your time zone and situation for that handy. But right now we're going to, and we're staying on time, so I'm happy to say. So right now we're going to move on to our two brief oral presentations. The first one is by Fabrizio De Benedetti, who will speak on his abstract macrophage activation syndrome in systemic juvenile idiopathic arthritis, treatment with emapalumab, an anti-interferon gamma monoclonal antibody. So, Fabrizio.
Hello, Michael. Nice to see you.
Yes, likewise.
To see you all. Hope you can hear me and you can see my slides.
Perfect. Everything's great.
So these are the final results of the trial with emapalumab in MAS in systemic JIA. These are our disclosures, a bit too many to read. I certainly won't tell you what MAS is. I just want to point out that overproduction of interferon gamma has been correlated with severity of MAS in patients, and that in some animal models of MAS, neutralization of interferon gamma is effective. With this rationale, a few years ago, we designed an open-label singular multicenter study to evaluate safety, tolerability, PK, and efficacy of emapalumab in patients with systemic JIA who developed MAS and who had failed high-dose glucocorticoid. Screening of up to 1 week, first dose at 6 milligrams per kilogram. This was based on the level of CXCL9 in patients with MAS in preclinical study. 4 weeks of treatment at 3 milligrams per kilogram, essentially twice per week, and then a 4-week evaluation following the last dose. There were 14 patients enrolled, 11 in Europe and 3 in the United States. All patients had failed high-dose glucocorticoids. 10 of them had been treated with anakinra prior to emapalumab. Here are the baseline feature: median ferritin, platelet relatively low, but not that low. Liver involvement was significant, and the dimer were increased. Neutralization of interferon gamma was effective, as you can see by the rapid decrease in CXCL9 levels. And by day 14, 2/3 of the patient had a CXCL9 level below 300 picogram per ml. We used as primary efficacy outcome complete response based on evaluation of clinical signs and symptoms by the clinician and objective measure of laboratory parameter as they are listed here, with normalization of blood cell count, almost normalization of liver involvement, and coagulation abnormality. 7 patients stopped emapalumab treatment early because of achievement of complete response before the day 28. 7 patients received emapalumab until day 28, so that the foreseen period of time, and 1 patient received emapalumab a little longer. 13 of 14 patients achieved complete response at week 4. At week 8, at the end of the study, 11 out of 14 patients had complete response. 2 achieved complete response at week 4, but not at week 8. 1 had just white blood cell below the lower limit of normal, and 1 had LDH right above the criteria for complete response of the trial. Most of those patients were able to permanently taper glucocorticoid in 12 of the patients by at least 50%, and in 8 patients below 1 milligram per kilogram per day or prednisone equivalent. There were no new safety signal in this study. Essentially, there were most of the patients had at least one event. 4 of them were considered related to study drug. There were 7 SAEs in 6 patients. 1 patient experienced a CMV reactivation that was possibly considered as related to emapalumab. There were no deaths and there were no adverse events leading to withdrawal of the drug. In conclusion, in this first analysis of this trial, the database lock was just a few weeks ago. The treatment of emapalumab resulted in rapid neutralization of interferon gamma. Treatment with emapalumab as a chosen dosing regimen, as demonstrated by the rapid decrease in CXL9. Emapalumab was rapidly efficacious in controlling MAS, and essentially all patients achieved complete response as based on the objective criteria. There were no new safety signal in this study, and these results support the pathogenic role of interferon gamma in mass during SJIA, and the therapeutic value of interferon gamma neutralization in patients who have failed standard therapy with high-dose glucocorticoids. And I'll finish here. I'd like to thank you all for your attention, and I'll take questions if there is time. Thank you.
Sorry.
I think you're muted.
Excellent. Yeah, yes, I'm back on now. Yes. All right. Thank you, Fabrizio. That's great. We may have time for like one brief question. Raise your hand. Use your hand. The raise the hand feature. And well, let's see. I think Randy might have beat Ashish to the punch here. So go for it, Randy.
Thanks. Very nice, Fabrizio. I'm just curious as to the kind of the dose range that people consider anakinra failures.
There were all sorts of dosing from 1 to 10. However, to be enrolled in this study, you need to be on a dose lower than 4. That would be 4 milligrams per kilo. That would be considered the dose effective in standard control of autoinflammation in SJIA, rather than the high dose that we all love to use. But this was the inclusion criteria of the study.
Okay, great. And any other questions? I'd say let's just put them in the chat box, please, because we need to move on to stay on time. So our next brief presenter is Jan-Inge Hinter, who is going to present response to MAP kinase inhibition of neurodegeneration at LCH monitored by CSF neurofilament light chain as a biomarker. Okay, Jan-Inge, can you?
Yes, I'm here. I need to get my slides on. I'm disabled so far, but I hope Kathy will let me in.
You should be able to share.
So
I just gave you permission.
Now it comes.
Yeah.
Now it comes. Sorry for the delay, but it was not possible before. So I'm very happy to give this presentation because it will hopefully help children with neurodegenerative LCH and hopefully help clinicians to treat these children, and also because it's a personal goal that partly has been accomplished. So I will report on successful response to peptide inhibition on neurodegeneration in LCH monitored by CSF neurofilament light as a biomarker. And this is just a short slide to say that neurodegeneration in LCH is more common than previously thought, but I will not go into details on that because of time. But because of that, we've been searching for a relevant biomarker in neurodegenerative LCH for quite a while, also partly because the clinical and MRI processes are so slow. And now we found one, or we have found for a while, which is neurofilament light in the CSF. This is a sensitive and established biomarker of neuroaxonal damage and a general indicator of neuroaxonal damage in clinical diagnosis. And also we have been studied before that it is most elevated in the most severely affected children with neurodegenerative LCH. So now we wanted to look at this in in patients with MAPK inhibition. So we've studied 5 patients with CNS LCH, 4 with neurodegenerative disease, and 1 then with CNS LCH only. And 4 of them had impaired cognitive functions, 2 had neurological symptoms, and 3 of them had at least 7 LCH-directed drugs prior to MAPK inhibition. And we gave 4 of them dabrafenib, and 1 was given tablet. And here are the results. So here you have neurofilament light in the CSF on this level, and normal levels are below 380, marked by this line here. And here this time, this is in months. So 48 months is like 4 years. So these are repetitive analysis over time for 4 years. And you can see that they were all above normal levels. And then we gave MAPK inhibitors, and the normalized, this is it within the blue area here. Second patient had a CNS LCH only, but was abnormal in levels. So we gave treatment and the patient normalized. The same again for patient 3 with more than 3 years of elevated level, normalized again in NFL level quite promptly. 4th patient the same, 5th patient the same. This took 9 months, but in most patients it was within 3 to 6 months. So they normalized the levels within 9 months after initiating therapy. Moreover, we studied 12 other patients without CNS LCH, and they had normal levels in 16 out of 7. These are MRI findings. I just take this very briefly, but this is prior to treatment, and here you can see increased T2 signal in dentate nuclei that then resolved after treatment. And you can also here see this multilobulated pineal gland that normalized also after treatment. Of note, as in other patients, NFL increased again after stopping therapy, as you can see here. So after stopping therapy, levels increased again, and the same was the case in this patient within 3 to 4 months, something like that. So the next steps, as we see it, in order to reduce neurodegeneration is first to identify patients at risk, and we have this information already. Then to monitor CSF NFL at regular intervals in these patients at risk. And then if the CSF NFL is elevated, then act. Perform broad CNS investigations, consider relevant treatment, and monitor NFL in the CSF and potential mutational load as well. So we conclude that NFL in CSF is a useful biomarker to detect and to monitor over time neurodegenerative LCH, and that MAPK inhibitions inhibitors are able to markedly reduce neurofilament levels, suggesting that they can inhibit LCH-induced neurodegeneration. So with that, I would like to thank my enthusiastic co-authors, other LCH collaborators, and thank you for your attention. Thank you very much.
Great, excellent. Thank you, Jan-Inge. So I think we have time for perhaps one brief question. Ashish, is your hand raised for Jan-Inge, or is that from the prior presentation for Fabrizio?
Sorry, that was from prior. I'll take it down.
Okay, all right. I have a question. I don't want to preclude anybody else, but oh, looks like Astrid does. I'll let Astrid ask her a question.
Oh, that's very nice. Thanks, Mike. Very nice, Jan-Inge. I think a very obvious question is, do you see any correlation with the response to therapy and the specific mutation that was found in these patients?
So they all responded well. And we have 4 with BRAF mutations and 1 we did not find a mutation, but they all responded well. So 1 was given tametanib because we didn't find mutations.
Mm-hmm. All right, and then I'll ask my question because I think it's brief. Is there a clinical avenue for measuring neurofilament light? I know it's probably in your paper how you guys did it, but do you know of any clinical labs around the world that do measure it?
We measure it, of course, also in a clinical setting in Sweden, not in our lab. So this is set up as for clinical studies. This is also actually included in the Stratum 5, and it's done. I think it's done in France, as I understand. I don't know the details.
Okay, great. All right. Okay, thank you, Jan Inge. Thank you both, the speakers.